Thank you very much. Hello and welcome to today's informational call. Today we will be talking about the IHI Leadership Alliance, which is a global healthcare leadership learning community united for change, driven by collaboration and focused on results. CFHI has been a member of the Alliance throughout its first year. As the Alliance now moves into its second year, it continues to welcome new partners. As you heard, I'm Stephen Samus, Vice President of Programs here at CFHI, and I'm pleased to be your host today. And I'm going to introduce our speakers shortly. And as I introduce the speakers, please take a moment, those of you on the line, to introduce yourselves in the chat box. Who you are, where you're from, as well as any questions you may have at the outset of today's call. So I'd like to introduce our first speaker, Dr. Don Berwick, who is the President Emeritus and Senior Fellow for the IHI. He's the former President of the IHI and former Administrator of the Centers for Medicare and Medicaid Services. He's a pediatrician by background and has served on the faculty of the Harvard Medical School and Harvard School of Public Health and on the staffs of Boston Children's Hospital Medical Center, Massachusetts General Hospital, and the Brigham and Women's Hospital. Dr. Berwick is recognized as a leading authority on healthcare quality and improvement and has received numerous awards for his contributions. Also joining us today is Dr. Saranya Lehrer. She's the Executive Director of North American Strategy and Operations for the IHI. She leads efforts to accelerate health system transformation in the U.S. through the development and execution of key programming, including stewardship of the IHI Leadership Alliance. Dr. Lehrer received her medical degree from Loyola University of Chicago's Stritch School of Medicine and her Master of Public Health degree from the Harvard School of Public Health, where she served as a Zuckerman Fellow. I'd also like to introduce Mr. Joran Hendricks, Chief Executive of Learning and Information, Kulturm County Council of Jönköping, Sweden. He has over 20 years of management experience in the Swedish healthcare system. Kulturm is a center for quality leadership and management development for county employees and for regional and national healthcare. He's a member of the Jönköping County Council Strategic Group, has been project director for the Pursuing Perfection initiative over the last 4 years, and is a senior fellow of the Institute for Healthcare Improvement. Mr. Hendricks is part of the Strategic Committee of the International Forum on Quality and Safety in Healthcare, organized by the British Medical Journal and the IHI. Finally, I would also like to introduce Jen Verma, who is Senior Director, Collaboration for Innovation and Improvement here at CFHI, and Jen is participating via chat today. On today's call, we're going to start with an introduction to the impetus for the Leadership Alliance. We'll hear about what and who comprises the Alliance and what has been achieved since its formation in mid-2014. We'll also hear where the Alliance sees itself going over the next year, including what this could mean for any Canadian organizations, and then also how Canadian organizations may become involved. I'm also pleased to say that we'll hear from Joran about his organization's experience participating in the first year of the Alliance. Now, a little bit of a word about us. The Canadian Foundation for Healthcare Improvement is dedicated to working with healthcare organizations to accelerate improvement in healthcare for Canadians across the country. We support spreading healthcare innovations across Canada. And in 2014, we worked closely with partners to bring about real improvements in the quality and efficiency of patient care, as well as spreading innovations in healthcare delivery. In fact, in 2014 alone, we supported nearly 800 healthcare leaders through over 140 improvement teams, 10 collaborations, and 2 rounds of our executive training or extra cohorts. Of those 140 improvement teams, we should note that 19 have come from CFHI's work in partnership with the IHI to facilitate the Triple Aim in Canada. In fact, we've supported 19 Canadian teams to enroll in the Triple Aim Improvement Community, which took place from 2013-14, and the Better Health, Lower Costs for Patients with Complex Needs Collaborative, which began in 2014 and is wrapping up just this month. And on March 13th and March 12th and 13th of this year, we hosted Canada's first ever IHI Triple Aim workshop in Toronto in collaboration with Health Quality Ontario and the IHI. Those 2 days brought together participants from across 8 provinces in Canada. At our March 12th, 13th IHI workshop on the Triple Aim, we walked away with some new insights, and specifically what we really thought of as 6 important lessons, or 6 Ps, that came to light. And these are important because they're crucial to what the IHI Leadership Alliance is aiming to achieve as well. So we thought we'd share with you those insights that we got from the Triple Aim workshop as an introduction to the work that the Alliance is trying to do. The first P was purpose. Defining purpose is about capturing the why and the so what. It must be clear and compelling, enough to hold a group together through challenging times as a reminder of what's at stake. Together, the Alliance has defined a set of radical redesign goals for improvement, which were recently referenced in JAMA by Don Berwick, Derek Feely, and Saranya. And together, we've outlined shared purpose through the Alliance. The second P is population. Top of mind for Canadians is better serving populations that use a high proportion of health care, but may not be largely because they're not getting the care they need elsewhere, including in social care. They're often referred to by many people as the 5%. This is the stuff of population management, but it's also about so much more than identifying segments stratified by common risks or needs. It's about working with a population to improve population health. Members of the Alliance are focused on the health and healthcare needs of specific and diverse populations and working with these populations to improve their health and care. The third P is players. And Triple Aim is really about moving beyond healthcare's traditional silos to broader collaboration inside and outside of health. Players collaborate across sectors, and the term players here means collaboration way beyond the usual other P that we often talk about in healthcare providers. The fourth is precision. Triple Aim is about knowing how good you are. Do you know where your variation exists? Is what you're doing delivering what you thought it would? These are the kinds of practical questions that has guided Triple Aim thinking in Canada and around the world and really is key to the work that members of the alliances are doing. Next, we have portfolio. What changes will we make? What changes are we already making that are showing Triple Aim gains? And which of those changes are transferable to others? Many members of the alliance are asking themselves these questions. And finally, persistence. Triple Aim takes focus, commitment, and an ability to find comfort during times of uncertainty. It's about persevering and staying the course, even in the face of significant community or organizational change, churn, and adversity. It takes persistence to get Triple Aim off the ground and to move to spread and scale. So why the Leadership Alliance? At present, CFHI is the only Canadian organization enrolled in the Alliance. We're there as an observer organization to really learn about the work that the over 40 organizations that are part of it are committed, who are committed to radical change and striving to achieve 4 aims. And we're really interested in learning about how these teams are actually going to do this. Those 4 aims are, 1, developing and implementing new models of high-quality, high-value care. 2, building high-performing cross-functional leadership teams. 3, enhancing organizational capability and capacity for improvement. And 4, creating a collective voice for system leaders. So we're featuring the Alliance on this webinar to introduce it to a wider Canadian audience and to provide Canadian organizations with more information about the Alliance, including its goals, activities, and its next steps. So with that, I'd like to now turn it over to Dr. Don Berwick, who will speak more to the Alliance, and then he will pass it on to Saranya and then Joran. Dr. Berwick, over to you.
Thanks, Stephen, and thank you for the chance to join you in this call, and I'm thrilled by the amount of interest being shown for those of you that are taking your valuable time to hear about this. I am, as Stephen said, the former CEO and now President Emeritus of Institute for Healthcare Improvement and a senior fellow. My major assignment there, among a number of them, is to help support the development of the Leadership Alliance, as Stephen has introduced. And I want to explain where this all came from. IHI has a long history of work with networks, groups of organizations that get together to accomplish common purpose. But the ground continues to shift. The 2 major shifts that I think lead to the Leadership Alliance initiative are, first, the clarification of the Triple Aim as a proper and useful way to designate the social need for health and healthcare. Prior to the Triple Aim, IHI's main focus was on the experience of care, safer, more effective, more patient-centered, timely, and efficient and equitable care, which remains crucial to IHI's mission. But beyond that now, we understand that improving the health of populations and reducing per capita costs it's simply an imperative in all nations around the world, but certainly here in North America. I personally believe that the momentum toward the triple aim is unstoppable now because the social need is so strong. The only question here is, will this be done from the outside in which governments, regulators, payers push healthcare system, in fact, try to seize the reins and make healthcare do what society needs it to do? Or will it be inside out? Will the healthcare organizations, the leaders, the systems understand the need, as happens in all industries, to change the way they think about their own work and to redesign the products and services and directions they're moving? This doesn't have to be a conflict. The outsiders and the insiders can collaborate, but there's really a kind of turning point, I think, worldwide now about whether healthcare is going to have the will and the momentum and the social systems to change itself for pursuit of the triple aim. That's not a proposition I would have put on the table 5 or 8 years ago because the triple aim wasn't on the table, and organizations were trying to perfect their care, but not necessarily their impact on health and total cost. Now that's changed, and IHI senses that there is a subset of healthcare delivery which is really willing to embrace this mission for real, both on mission grounds, it's the right thing to do, but also because they understand that their future will be brighter if they can be active supporters, active players in the thorough redesign of care. The current care systems won't do it. They're not capable. We know that. We need a new design for meeting the new need, the triple aim need. So IHI put out a call. It said, can we form a collective, a network of organizations willing to get together, share their ideas, scan the world, establish better and better understandings of the principles of new design, and execute, carry these out in total support of each other as examples for the world. There's a group of these organizations in England now. They're calling themselves the Vanguard Group. That's not a bad way to think about this. So the Leadership Alliance was intended to be a vanguard, organizations that are willing to say, we understand the social need and we're going to change, but we'll do it together. We made a commitment to do that when we first formed this network now over a year ago, and it's stuck. The people are engaged. We have, I don't know the number right now, Sonia will bring us up to date, but it's well over 40 organizations that are working together, and I think we stand a chance of changing the landscape. We'll do it with the initiatives that Stephen recited, by making a commitment to achieving the triple aim, developing metrics together that we're willing to use, clarifying the new design that's going to be needed to achieve those metrics, working on leadership activities, and especially joy in work, which is a crucial idea in the Leadership Alliance. This should be done with a sense of pride and celebration on the part of the workforce, and we have to figure out how to make that more feasible and help leaders do that. And finally, do it publicly. Do it as spokespeople, a collective voice that's going to speak out about the feasibility and the desirability of inventing new healthcare. That's pretty big talk, and we know it, and we know it's going to be a long journey, and we know everyone has a lot on their mind, but it's going to be inside out or outside in, and I prefer that those who give and offer care take responsibility for the redesign that is achievable. Now, Canada. IHI, from its very formation, its original charter mission statement, specified the U.S. and Canada as the areas of its focus. Later, we added the rest of the world. But there's a very, very long history of connection between Canada and the work of the IHI, a happy one, a wonderful one, many colleagues, many connections, and now thriving in this current connection that Stephen described through several channels. I'd like to see that expand and grow, and one way to do that is to hope that you on the Line and other organizations throughout Canada will be willing to become part of the Leadership Alliance, full-fledged participants in redesign. In Canada, of course, the financing context, the history, the provincial role, the national role is different from in the U.S., but that's good. We can learn from each other and grow together, and I actually think Canadian participation in the Leadership Alliance will help the American or the U.S. organizations and vice versa. I'm delighted by Stephen and Jen's willingness to act as leaders in this endeavor, and I really look forward to tighter and tighter connections with between our organizations. So that's where we come from. The Leadership Alliance is bold. It's an effort to really make changes. It isn't just about talking. Highly collaborative, a lot of exchange of ideas, highly global in the way we're going to think and network and look for new designs, and hopefully joyous. We're really trying to create an environment which is distinctively positive, as people experience the fun of reinventing the work they care about. I think that's the most I can say right now. Saranya, let me turn it over to you, and I'll stay on the line for a bit longer in case people have specific questions for me.
Don, thanks so much for that and for the origins of the Alliance, and it's my pleasure to talk you through some of what we've been doing for the past few months and where we're headed as well. So as Don said, September 1st, we made a commitment as an alliance, and these are the organizations that came together with a common purpose, which was to deliver on the full promise of the Triple Aim. On October 7th, we actually physically came together to start building our community and really made this commitment to figure out what it would take to have care better than we've ever seen, health better than we've ever known, and at costs that we can all afford for every patient every time. And then finally, we started taking action. And so here is, you'll see a group of us. You will see Stephen and Jen somewhere in this. This is our group that just met a couple months ago in San Francisco. And here's how we, and you'll definitely see Jen in this one. I don't have an arrow, but you'll see her taking some notes. So here's what we did. For the first half of the Leadership Alliance, we said, what are the tools that we need to arm ourselves with to really achieve what we want to achieve on delivering on the full impact of the Triple Aim? And so we thought about 4 different tools that we really needed to have at our disposal. We needed to have an aim that we all stood behind. That was probably the easiest part. And then we had to have a conversation about measures. What are the measures that we need to either identify that already exist or develop if they don't exist yet? And how can we use those to measure and assess our progress? Don and Stephen had referred to this too, of radical redesign. If you look at the original 10 simple rules from the Institute of Medicine report, in many ways they focus on one aspect of the Triple Aim, not all 3. So if you're trying to do all 3 together, what are new approaches to care redesign that need to serve as our guideposts? It's also leadership. What are the skills and attitudes and behaviors that we need to be able to create to help lead organizations toward this new era of healthcare? And then finally, collective voice. We often hear that being at the cutting edge can be a lonely place. So how do we take the collective insights and learning and progress to really shape in an amplified way the national dialogue around health and healthcare? So for quite a few months, we focused on those 4 tools that we wanted at our disposal. Here's just a list of the radical redesign principles, and the picture that you saw of Jen and others were looking at how to take these ideas, these guideposts, and actually turn them into action. How would you operationalize them? So we've been having a lot of fun thinking about what it would mean in healthcare if you assumed abundance, or if you collaborated, eliminated walls, if you move knowledge, not people, and certainly something that we're learning from all of you in Canada is the piece around returning the money and how you take the savings and actually invest it in your communities. Around collective voice, there are a number of things that, some of which Stephen has already mentioned, the JAMA viewpoint that I know Jen put into the chat, and then also our own organizations themselves talking and localizing this to their context. So Gunderson Health System as well as Kaiser, talking about what this means to them, their members, and their communities. So now we're taking the tools that we've been developing and refining and applying them in service of the Triple Aim as well as joy in work, which we know is a particularly important lever for many organizations, certainly in the U.S., and we appreciate that it resonates throughout the world. So the 4 areas where we're focusing are creating a joyful workforce, co-creating an optimal care experience, improving the health of the populations we serve, and reducing per capita costs while improving affordability. And here's how we're doing it. We're taking those tools that we have, applying them in those domains in a couple of ways. In harvesting, there's a tremendous amount of promising practices that already exist within the organizations in the Alliance. How do we make sure that we know the best of what each other is doing so we're not reinventing the wheel? Scanning, which is, well, where do best practices already exist, maybe outside of the Alliance or, in fact, outside of healthcare, and how do we bring that learning to Alliance members? and then also testing, so we can develop some new models, new frameworks, and new ways of delivering care and working together. So in year one, as a quick recap, we're finishing refining the tools that we've been creating, sharing some innovations and ideas, doing some local testing, and finding our collective voice. And our goal in year two is to really apply those tools, learn together, move the needle, and spread the message, so that the Alliance can access the most promising examples of what exists that can lead to breakthrough performance, have a common set of frameworks and measures that help us actually accelerate our ability to move from ideas to action, and then continue to learn from one another so we can serve as exemplars, not just for our colleagues in North America, but really around the world. I just want to end by kind of, when I think about the Leadership Alliance, I think about them sort of, really like Stephen's 6 Ps. There's 3 things I think that really characterize the Alliance. Is they're generous. They really share, they're very open about sharing with one another about what's working and, importantly, what isn't, so that people don't have to reinvent the wheel. They're curious. They're interested in moving beyond the status quo, beyond their organizations, beyond their industry, beyond the models that they traditionally use to really push the boundaries. And I would say that they're also very courageous. They're willing to stand out there and be spokespeople for the future, to lead the way, and importantly, to show others how as well. And I suppose I'll add just one more. They're confident. They're confident in that, but that by sharing and learning together as an alliance, as opposed to doing it alone, they'll be able to get better, both individually and collectively, much faster. And so that's the perspective from IHI, and importantly for all of you on the call, you'll certainly want to hear the perspective of Alliance members as well. So we're very grateful that Joran is willing to speak to his experience and his organization's experience being part of the Alliance. So Joran, please take it away.
Thank you very much, and thank you all for having me in this call. It's fantastic to be a part of a global community, and this is one of the reasons why we think IHI is so important for us, because they open the doors for a global learning, and I think that healthcare more generally needs that kind of learning approach. We are so specialized today that we need all the support we can get to understand where we are heading. And just as Don mentioned, the other part of this is that our challenges are outside our own system in the coming years, and therefore the alliance approach is a very positive way to work. The County of Jönköping has since '96 had a business idea that is pronounced to have quality as business strategy, and a vision that says that we should help people in our region to have best possible life. And in that perspective, the work in the Leadership Alliance and the 4 different angles or pillars in it has worked very well for us. We have seen that the view of focus on people and individuals are exactly what we need, and by participating in the alliance we have got the courage to do that even more. We also have got a deeper understanding of co-design and co-production. And I think, just as Don mentioned, that joy in work has been a very natural thing for us, but hearing from the other systems how they really try to inspire the employers to see new ways of doing things have energized also us. I also think that the group around measurement was exactly what we needed, because the timing of redefining new good system measures are so good. When the social aspects comes to the dashboard, you need to think through what are value for the inhabitants and how can we contribute to that with our methods and competence. So we really appreciate the collaboration around new system measures. And joining the Leadership Alliance, you also develop a kind of humbleness of your own frustrations. You see that many other groups deal with the same challenges, and that develops the leadership, because leadership is much more about taking care of dilemmas than finding the final solution. So please come with questions to me if there is anything that resonates to your mind when you hear my description of our experience.
So I am happy to answer some questions while we're waiting, and I love that I've got a general question till we hear music. So if folks can hear me now, I think I will. Let's see. I'm going to pivot to one of the nuts and bolts sort of questions, which is. Oh, here we go. So just a couple of the nuts and bolts, because someone had asked about how this group actually interacts together, which is a great question, as well as a question around governance structures. So the program year, it's a year-long membership. It's from September 1st of 2015 to August 31st of 2016. And organizations engage in a number of different ways. We have a very important and personal onboarding process where we'll speak to leads at every one of these organizations to understand what are the assets that you are bringing to the Alliance and what are you most hoping to get out of it. What are some of your pain points and key strategies over the next coming months that you'd most like to focus on? So we get a really good sense of how every individual organization can best benefit from their participation in the Alliance. And then we can also help think through who might be the best people in your organization to engage. So if you look down at Alliance activities, there's a couple of things that we do. So every month, there's usually at least two, looks like someone's saying that the speaker is cutting out, which is me. So if that is still the case, I apologize, let me know and we can work on that. But for the Alliance activities, those 4 domains that I mentioned, joy in work, care, cost, and care, cost, population health, and joy in work, those 4 domains will have anywhere from 1 to 2 calls a month where we'll be doing the work that we were talking about, the harvesting, the scanning, and the testing, so that we build those common measures and common frameworks and get to common action together. So any number of individuals within your organization are able to participate in those monthly calls, so that's unlimited. And organizations tend to decide who they have join what calls and how many of those domains to be involved in. We have a number of organizations that are involved in all 4 and some that just pick 1 or 2 that are most relevant to their organizations. We also have quarterly all-Alliance calls where everybody in the Alliance comes together, and those are a little bit longer. They're going to be about 90 minutes. And it's an opportunity to both hear about what everyone else is doing, so we all stay informed and up to date about all the great work that's happening in the domains. And it's also an opportunity to hear from some outside speakers that might help really evolve our thinking. The next year, we'll likely hear from Dr. Atul Gawande, Rebecca Oni from Health Leads. Actually, just in a couple of weeks, we'll be hearing from Dr. Neil Shah, who runs an organization called Cost of Care. So those are great opportunities to bring in some outside speakers that really help us advance our thinking. And then finally, and again, those are open to anyone in your organization. And then finally, there are 3 face-to-face meetings each year. And because those are in person, we unfortunately have to limit the number of participants per organization a little bit, just for capacity issues. And typically, around 3 to 4 people from each organization are able to attend the face-to-face meetings. So with that, I know that the CFHI folks are back on, so I'll pivot back to them and see where we take it next. I know we've got a lot of questions in the chat that we're happy to answer.
Great. Thanks, Serenia. Well, there's a first time for everything. That's the first time we've been dropped from our own call, so that was very interesting and exciting. Anyway, here we are back online, and we do have a question. This one for you, Serenia, about the common frameworks and measures. How have the measures really been decided, and to what extent are there common measures that the Alliance members are using?
That's a great question, Stephen. And so that's, as we said, the remainder of year 1, we're still working on refining the tools, and it's of particular importance because the IOM just came out with their the vital signs, so a set of measures that they think are important to consider. And there's a new group that is actually a group of CMS as well, the Centers for Medicare and Medicaid, and a number of private payers who come together to talk about measures as well with the National Quality Foundation. So we're looking at all of them to try to streamline. One thing that we are very grateful for in the Leadership Alliance is our partnership with the Dartmouth Institute that has really helped, and I know Steve and Jen, you were there, has really helped us look at measures as an alliance. So we looked at a couple of different measures around that we can get access to in the United States so far. So a well-being measure, a measure around patient experience, so how likely they would be to recommend their care and that organization, things around 30-day readmissions, cost by hospital referral regions. So the Dartmouth Institute has a wealth of that information available for, in particular, the U.S. context, which is what we were exploring. And what we did is we looked at where's everyone nationally? What are what's the spectrum nationally? And then where do Alliance members fit in a number of those domains? And it led to a really interesting conversation because there was tremendous variation even within the Alliance around things like the experience of patients as they receive care in these settings, as well as the Community Well-Being Index. And it provided a lot of opportunity for us to think about, really reinforce how we can share with and learn from one another. And I just saw that Alberta is asking about community measures, and that's when you looked at the identifying and developing the measures by which we will assess our progress, that's very much in the developing measures phase, and we're very pleased to see that the IOM report has a lot of focus around community, and we look forward to sort of working with them to flesh that out. And a number of you might also be part of the 100 Million Healthier Lives campaign, which is also looking into the community measure space. So we're collaborating wherever possible on some of those measures, because we know that what organizations want are not more measures, but a much smaller, parsimonious, balanced set of measures that matter.
And Serenia, there's also a related question here about measuring leadership and leadership performance, both quantitatively and qualitatively. How is that being done?
So that's the leadership piece has evolved slightly, and we have something called the High Impact Leadership Framework, which we're happy to send around, or perhaps we can put a link to it in the chat. And a lot of the leaders have been working on how they evaluate sort of themselves, as well as how individuals within these organizations evaluate leadership. And so it's been an interesting conversation about the sometimes disconnect between those two. What's been, I'd say, most interesting about how the leadership group has evolved is that they have gone so clearly in the direction of how, as leaders, they can help create the conditions that allow for a happy, healthy, resilient workforce. That has been almost entirely the focus of the leadership work group, and so much so that they want to actually make that their own entire work stream in and of itself.
And then one other here. How can we define or determine a joyful workforce or workplace?
That is another great, that's another piece around measurement as well as best practices. So one of the things that Alliance members have been doing over the course of the past few months have been harvesting best practices of what they do within their own organizations, whether it's developing staff asset maps. Health Partners has a phenomenal wellness program called Be Well that they've been employing within their own organization. So they've been looking at what they're already doing within their organizations, within the organizations in the Alliance that promote that promote joy, health, and resiliency within the workplace. We're also looking outside of healthcare, so that's the scanning phase that I talked about, and we're looking at, there's a number of very high-level organizations, not in healthcare, that have very low rates of employee turnover, but very high rates of employee satisfaction. So we're actually in talks with a couple of them to see whether or not they'd be willing to come and present on an upcoming call so we can learn a little bit about what that means. And the final piece is around measuring and how do you measure that. There's some interesting measures and work happening at Mayo around burnout. There's interesting research being done now about measures around resiliency. And most organizations are measuring at least satisfaction or doing quick pulse surveys or things to get the tenor of their organizations. And so what we're doing is compiling what those are so we can learn from them and talk about what might be some best practice measures that everyone can test out so we can assess our progress over time.
Great, thank you. We have another question here, and apologies if you already addressed this one while we were off, but to what extent are boards or governors of the organization typically involved in participating in the Alliance or approving the direction that their teams in the Alliance are taking?
That's a great question, Stephen, and you know, it's something that I actually did not, I think I was remiss in talking about, which is that the organizational membership of the Leadership Alliance is at the higher levels. It's called the Leadership Alliance for a reason. So this is not as much about the day-to-day frontline improvement that a number of IHI offerings are. We certainly value that tremendously. This one is particularly focused around leaders. So CEOs, CMOs, CNOs, Chief Quality Officers, medical, nursing, quality directors, so people who are in a position in which they can actually create the conditions in which radical redesign can occur. So those are the types of participants that join. And some of them actually do have their boards involved, which is neat, and some of them don't. So it's really a matter of which organizations think about that. And another thing that we have is we do have a number of hospital association or governance type organizations that are not necessarily tasked with delivering healthcare themselves, but support large organizations, somewhat like CFHI, who take on the learning and then curate it and disseminate it to their organizations that they're a part of.
Great, thank you. We have another one here for you, Saranya, and that is looking at the question of how has the Alliance been able to show optimal patient experience to date? And so what's that relationship or dynamic for the patient experience and then the provider experience? Maybe if you could expound on that a little bit.
Sure. Well, a couple of great examples come to mind. One is some of the work that Bellin is doing. Bellin is a healthcare system member of the Alliance in Green Bay, Wisconsin. And they've done a lot using this technique called patient river mapping and looking at truly engaging patients as a co-partner in care redesign. And they've done it in a number of ways, and they've presented on how they engaged with a particular patient or with particular patient representatives around redesigning their GYN-ONC service line. And we're very fortunate that some of those patient representatives were actually on the call and kind of coaching us in how we might apply some of that, or how Alliance member organizations could apply some of that within their own organizations. In addition, we had a great presentation by UPMC, which is a health system in Pennsylvania, in the state in the United States. And they talked about a couple of things that they did related to falls, as well as pain management, in a way that completely redesigned the way they assessed for falls, that was much more beneficial to patients, way better for providers in terms of reducing administrative waste, administrative burden, so they could actually spend more time at the patient's bedside. And that approach actually contributed to a reduction in falls entirely. And they used a similar approach around pain management and waste reduction. So those are just a couple examples of what the Alliance does, which is taking issues like that about how do you redesign the care experience and how do you do it in a way, importantly, that is better for both patients and providers. I think that's a very important point, and have been sharing best practices left and right with one another, and have been willing to follow up and help coach one another and how they might be able to apply that within their own organizations.
And Serena, we have a question here from Francine Lemire, who is the CEO of the College of Family Physicians of Canada. And so her question is there a role for professional associations as part of the Alliance? She says it's obvious here. I can see a good link to this for regional health authorities, and there are many delivery systems on the line. But the link for a professional association seems a little more tenuous. And could you comment on that?
Yeah, we actually have a number of what we call sort of industry organizations that are part of the Alliance, including, as I had mentioned before, in particular a hospital association. We're in talks with a number of other hospital associations to join as well, and those organizations are they're tasked with helping to disseminate and coach hospitals in sort of improvement within their own states. And so they have found value in the Alliance in taking what's been learned from not just their state, but all across the country and indeed the world, and bringing that to their members. And there's hospital associations. There's an organization called the Kansas Healthcare Collaborative, which is doing something very similar in Kansas. I don't know if CFHI, if you guys want to talk about sort of your experience and how you've been doing that. And I will say we're very grateful to CFHI, who have been sharing a lot of what Canadian organizations have been doing. We're grateful that actually Alberta Health Services came and spoke on, even though they weren't part of the Alliance, they were just doing such great work that we begged Jen to ask them if they'd be willing to present on a call, because there was so much for us to learn. And industry members will have a little bit of a discounted price, obviously, because it's a different type of setup than hospital systems. But I don't know if Jen or Stephen, you wanted to maybe share some perspective around non-delivery organization membership in the Alliance.
Well, yeah, I mean, it's interesting because, as a non-delivery organization, but as an organization that works very closely with delivery systems across the country to help support them to improve care and to work differently in care. The conversations we have found, the conversations at the Alliance, to be very, very informative, and and it's also interesting that the issues that teams are grappling with in the Alliance, whether they are small public health organizations or high-performing healthcare systems that we would know well in Canada, many of them are grappling with the same kinds of issues. And the kinds of transformative change that Don talked about at the beginning is a goal of all of the members of the Alliance. So it's very interesting for us to be able to observe and hear the conversations, to understand that these challenges are definitely cross-border and in fact global in nature amongst many healthcare systems, and then we can bring some of the lessons learned back to our programming, actually, within the foundation, and share some of the lessons learned that the organizations, and we hope as we enter year 2, be able to share back here in Canada some of the early successes and early wins that organizations are actually putting into place as they sort of move from assessing and designing the way they're working in the Alliance to getting into implementing some radical change and some specific change, and how they're measuring that. So those are really, I think, the things for an organization like ourselves that we find very valuable. In terms of other questions, I mean, one of the things I would ask you, Saranya, is, you mentioned the 4 areas of the Alliance earlier in your slide, and these are all very relevant to the Canadian context. What, from your perspective, and Don mentioned this as well, that the Alliance can learn a lot from the larger Canadian collective. What would you see as some of the real benefits that Canadian teams would bring to the Alliance, and how would it, how do you think it would change some of the dynamic at work in the Alliance membership?
Well, thanks for the question, Stephen. And I'll say just from your participation and Jen's participation in a lot of the domain calls, it's clear that the U.S. members actually really want to hear from non-U.S. healthcare organizations and healthcare systems who, in some ways, have a bit more of a permissive context and much more of a population community health focus that we are in the U.S. trying to catch up on, of course. But I noticed a couple folks in the chat talked about how much they value the work of Yoron and Yon Shipping, and so Alliance members have been very grateful to learn about that work, and we of course are grateful as well. And then, as Jen would often mention, the work that a number of organizations in Canada are doing around community health, around true co-production with patients and providers in radical redesign. This idea around the community wellness trusts that were being created and the way that Alberta Health Services were working on radical redesign for mental health services. And Alliance members were saying, we want to learn more. What are they doing? Can we see the tools? Can we see the resources? Can someone come on so we can understand, because in many ways you're ahead of some of the You're in many ways where we want to be in terms of our ability to really embrace the assets of the community in being true partners in care redesign. And so that's something in particular that Alliance members are interested in. When you look a lot at the radical redesign principles, I think there's a tremendous amount that we can learn, not just from our Canadian partners, but of course from Yon Shipping and other partners around the world.
Great, thank you. Yeah, I think the opportunity for mutual cross-border sharing and learning is really quite tremendous, which is why we were so interested in introducing the Alliance further and more broadly to the Canadian market. There was a question around the fees, I believe. Saranya, you wanted to speak to them a little,
Sure.
in a little more detail. So we've turned back that slide.
Okay, great. Yeah, I just wanted to note the pricing. And so we have the pricing both in U.S. dollars as well as Canadian dollars. And, we appreciate that the exchange rate can flux. And so we've locked in the exchange rate until August 15th. So even if the exchange rate changes, the price that we've locked in for today will not change between now and August 15th. So as you see the prices for Canadian members, that stays the same. And I didn't also mention cohort pricing. So we have a number of organizations particularly in our industry members or our hospital associations that want to join as a group of hospitals or a group of health systems or a mix of health systems and community health centers and primary care. And if there's a group of organizations that want to join, we want to make it a little bit easier on a price point for them to all join together. So if there's a group of organizations that want to come in, the price is discounted a little bit. And so you'll see the discounted price if 3 to 5 organizations decide to come in together, and 6 to 10 if the price point for if 6 to 10 organizations want to come in together as well.
Great, thank you. That's helpful for everyone to know, especially with the fluctuating rate. I just yesterday locked in a vacation home in the U.S. for August, and that's very important to have that locked in.
Well deserved. We look forward to having you on this side.
From Maggie. What was the term for the work around patient engagement? She said sounded like patient river mapping. And was the person's name, who was the person's name who was conducting the work? Was it Ellen?
So the work that they do, the tools and the strategies that they employ is called patient river mapping. She does have it right. And the organization that was sharing how they're doing that in their organization is called Bellin, B-E-L-L-I-N, and they are a member of the Leadership Alliance. And it was just meant to be an illustrative example of the types of harvesting, sharing, and learning that Alliance members do with one another. to help accelerate their individual efforts in these domains as well as the collective efforts and aspirations of the Alliance as a whole.
Great. Okay. I think I think that's it for the questions from the chat box so far, and I would invite any of the participants on the line to send in, one or two more questions. We do have a few minutes left. In the absence of other questions, Saranya, is there anything else that you would like to add about the Alliance, or you think the audience members should know?
Well, I'm happy to talk a little bit about the next steps. We would be more than happy and excited to speak with any of you. So you're welcome to check out our website where you can learn a little bit more. We also have a little bit more of a detailed prospectus that you can download as well. We'd be happy to speak with you, too. We always like hearing from organizations and chatting about what we're doing and answering any other specific questions that you might have. So you're always welcome to connect with us as well, and you have that information. If you'd like to, I know some of you mentioned that folks weren't able to be on the call necessarily, so you can replay this deck, you can share this with them, and we'd love to have some of you join us in the next couple of weeks.
Great. So there's the next steps you see on the slide. I'd like to thank all of our speakers, Dawn, Saranya, and Joran, for excellent presentations today, and to our producers, Kelly and Sheena, as well as Jen, for working behind the scenes here to make this webinar happen. If you could please take a moment to fill out our quick polling survey that you see now on the screen. We'd really appreciate it. This will help provide some useful information about where you see yourself in relation to the next steps provided about enrolling in the Alliance. And in particular, if you answer yes or no, or unsure about whether or not you or your organization would be interested in joining the Alliance, we'd really encourage you to, in the chat box, just provide a little bit of information to the presenters as to why or why not. That would be very helpful information for all. We'd like to thank all for attending this session and for your participation in today's discussion. And this will conclude today's information call webinar. Thank you very much, everybody.